Moving on. What is this? Again, this is quite easy for you. This is the cervical mucus in the proliferative phase. What is this called? This is the spin barcate. Spin barcate is actually a German word that just means ability to be spun. Meaning, this is a the mucus is very thin and it is stretchable. It is profuse and watery, giving it a woven like something that can be woven. So it is called the spin barcate endometrium. Spin barcate appearance of the cervical mucus. This occurs under the influence of estrogen, sodium and chloride. Okay, that is the spin barcate. Now, this mucus, the spin barcate makes the cervical mucus penetrable to sperm because it is that thin, it is watery, and it is profuse in amount. It makes it penetrable to sperm. What happens later on as the cycle progresses? As the cycle progresses and progesterone comes into play, the mucus loses its elasticity. It becomes thick and easily breakable. This is one condition. This is one prerequisite to prevent polyspermy also. This is called TAC. TAC is under the influence of progesterone. So once TAC has occurred, it becomes what? Impenetrable to sperm. All right, is that clear? Here, what is this that you see here? This is the ferning pattern. See, it is like a fern. See how it is like a fern? This is the ferning pattern that you can see on saline microscopy if you keep this mucus, that is the spin barcate observed in a saline microscopy shows a ferning pattern. Again, if you're asked what is the ferning pattern, when does it start? Ferning pattern starts from day 8 and lasts till and disappears by day 18 of the menstrual cycle. What is it under the influence of? Estrogen, sodium and chloride. Where else can it be seen? It can also be seen in PROM or PPROM, that is in amniotic fluid can also show the same because amniotic fluid contains sodium chloride. Okay, so that is about the spin barcate. Moving on to the next question. What is this image of? This is the image of Acanthosis nigricans. Acanthosis nigricans. What is it? This is a dark, smooth, velvety skin that is usually seen at the nape of the neck or the armpits. In fact, this is usually seen in people with obesity. This is actually the clinical manifestation of insulin resistance. So, where can you see insulin resistance in gynecology? Where is it seen? It is seen in PCOS. Insulin resistance is the hallmark of polycystic ovarian syndrome. You all know about the hair and right, hyperandrogenism, insulin resistance and acanthosis nigricans. In PCOS, there is increased androgen production by the ovaries that lead to increased DHEAs, increased LH and increased estrone. All right. So acanthosis nigricans you can see in PCOS. Going further with PCOS, these are two ovaries that show a polycystic pattern. See, it is very clear here. This is the ovary. You see how there are peripherally arranged follicles. When you say that an ovary is polycystic, it does not mean that this ovary is full of cysts. These are not cysts. These are just follicles that have failed to rupture and they remain there as such. These will not undergo torsion. These are not going to be infected. These are not going to rupture. Okay. So polycystic ovary means that the follicles remain there without rupturing. Why? What happens? There is a hypersecretion of LH. That is what happens. Now you all know about the Rotterdam criteria. You need 2 of 3 criteria. What were the criteria? First one is oligo or anovulation. That means she may be amenorrheic or she may be having irregular cycles. Then you need to have chemical or clinical features, biochemical or clinical features of hyperandrogenism. That is, she may be hirsute, she may have acne, she may have all these acanthosis, or you will have a serum testosterone measurement that is high. And finally, you have got the ultrasound criteria where you need 12 or more follicles, which is 2 to 9 millimeters arranged in the in the ovary. Any or the ovarian volume must be more than 10 cc. So any two of these criteria are enough. That means a girl or a woman who has got a normal ovaries on ultrasound can also have polycystic ovarian syndrome. What is not a criteria? What is not? You all know the criteria, but what is not a criteria for PCOS? Obesity. There are people who are very lean and still have PCO, which is called the lean PCOS. Obesity is not a criteria. You don't need this necklace pattern on ultrasound. You needn't have increased LH, FSH or insulin resistance. Okay. So another thing, now we come to the management of PCOS. You all know the first line management. See, you can get a question like this and you can be shown this ultrasound and then you may be asked just the management. You won't be asked to identify what this is. If you're asked the management, if you're asked what is the first line management of PCOS is lifestyle modification. What does that mean? That means regular exercise and a healthy diet, lifestyle modification. Now, if the question specifically says a woman with PCOS with infertility, what is the drug of choice for infertility in PCOS? In infertility, the drug of choice is letrozole, which is what? An aromatase inhibitor followed by clomiphene citrate. Next, how do you treat menstrual irregularities? How can you treat menstrual irregularities in PCOS? Here the drug of choice is oral contraceptive pills. How do you treat insulin resistance? It is by metformin. So these are the treatment modalities, any of which can be asked as a question. You're given the ultrasound. So a woman has come with such and such complaints. What is the drug of choice for infertility? Or she has got irregular cycles. This is her ultrasound. What is the drug you will give? Or this is her ultrasound. What is the drug you will give for insulin resistance? It is metformin. Do you understand this? Okay, now we'll go to the next question. This is an image of an instrument. What is this instrument? This instrument is the Leach-Wilkinson cannula. What is the Leach-Wilkinson cannula used for? It is used in hysterosalpingogram. What is done here? In hysterosalpingogram, an iodinated water-soluble dye is passed into the uterine cavity with this Leach-Wilkinson cannula. It is followed by serial X-rays. When is this done? From day 7 to day 10 of the cycle. That is, it is done in the pre-ovulatory phase. See, this is a normal HSD. I want you to look at how the dye has spilled out from the tube like that. This is a normal HSD. Can you see the Leach-Wilkinson cannula there? The cannula is there. The dye has been injected and since the tubes are patent, the dye has spilled out and then the X-ray has been taken. Alright. What do you use this for? What all things can you identify from the HSD? You can identify Müllerian malformations. In addition, this is the investigation of choice for tubal patency. Is this the best test? No. What is the best test for tubal patency? That is laparoscopy and chromopertubation. But here, the investigation of choice for tubal patency is the HSD. Where is it not done? Where is HSD contraindicated? You can be given this picture and asked, where is this procedure contraindicated? First of all, you have to know that this is an HSD. It is contraindicated in pregnancy, in active genital tuberculosis. It can be done in genital tuberculosis, but not when the disease is active. It is also not done in active PID. Why? There can be dissemination of the infection. So whenever there is an active disease, whether it is PID or a genital TB, then HSD is not done. What is the dye that is used? We said it is an iodinated water-soluble dye. It is urographene. The dye is urographene. All right. That is about HSD. So since we have studied HSD, we'll come to Müllerian anomalies. Müllerian anomalies is also an important topic for you. What is a Müllerian anomaly? You have got the Müllerian ducts which fuse together to form the female internal genital organs. That is, it forms the uterus, it forms the tubes, and it forms the cervix. Also, it forms the upper 2/3 of the vagina. The lower 1/3 of the vagina come from the urogenital sinus. The ovaries come from where? They come from the gonadal ridge. Fine. So, it is just the Müllerian anomalies. You have the tubes like that. You have two Müllerian ducts. How do they fuse? The fusion starts in the middle and then it progresses in a craniocaudal direction where this is completed like that. Now, anything can happen during the fusion of these Müllerian ducts. We'll take the first one. What is this? See how the fundus is divided. That is, the Müllerian ducts have started to fuse. They have fused in the middle, but it has proceeded caudally also. But this fusion is incomplete. These are two separate uterine horns. What does it have? It has got two separate horns. And it has got a single vagina. What is this? This here is a bicornuate uterus. Bicornuate means there are two horns. We said that Müllerian anomalies can be identified by the HSG. Look here, it has got two separate horns, right? But the fallopian tubes are all patent. How do you know? How do you know whether this is it is a bicornuate uterus or a septate uterus? In this case, you have to look at the uterine angle between the two corners. Look at this angle. This forms an obtuse angle. If it is an obtuse angle or the distance between the horns is 4 centimeters or more, that means that it is a bicornuate uterus. Okay. In the next one, what do you see here? It's already given there. This is a septate uterus. That is, the Müllerian ducts, both of the Müllerian ducts have fused, but the septum that has formed between them fails to resolve, which results in this, which is a septate uterus. The septum is remaining there. Look at this. This is HSG of a septate uterus. Now you look at that angle which is formed there. Look. The angle is an acute angle, right? If it is an acute angle or the distance between the horns is less than 4 centimeters, it means it is a septate uterus. What is this? This is a hysteroscopy. Hysteroscopy means what? You are passing a camera and a light source into the uterine cavity. You can see the cervical canal, you can see the uterine cavity, you can look for any abnormalities within the uterine cavity. You can also see the ostia of the fallopian tubes. So here, a hysteroscopy has been done and you find that the cavity is divided into two. This is a hysteroscopic picture of a septate uterus. Hysteroscopy is both diagnostic and curative in case of a septate uterus. What is the treatment of choice? It is a hysteroscopic metroplasty or a hysteroscopic septal resection. That is a treatment of choice for a septate uterus. All right. Shall we move on to the next one? There. What is this? Here, only one of the Müllerian ducts have developed. It is a single Müllerian duct. This is a unicornuate uterus. Only one horn is there. Look at the HSD picture. You can see that the Leach-Wilkinson cannula has been inserted. There is only half of the uterus. This part, this is called a what? A banana shaped. It looks like a banana only, right? A banana shaped uterus. Only half of the uterus is there, only half of the cervix is there, and only half of the upper part of the vagina is there. And there is also only a single fallopian tube. On the other side, none of the Müllerian structures will develop. You know what is important for the unicornuate uterus? All of the Müllerian anomalies have got something to do with the fertility. This is the one, the unicornuate uterus is the one with the worst reproductive outcome. This one has the worst reproductive outcome. Alright, because there is very little space for the baby to grow. Now we come to the next one. This is actually two entirely separate uteri. If in the previous question we have had only one of the horns developing, one of the Müllerian ducts developing, here we have got both the Müllerian ducts developing. Only thing is they are developing independent of each other. They do not fuse together. So what do you have? You have two entirely separate uteri within the pelvic cavity. What is this? This is uterus didelphys. Uterus didelphys can come with a single vagina or a double vagina. Know that uterus didelphys is the only condition where there can be two vagina. The only condition with two vagina. Alright, if it is unicolous, there can be only one vagina also. Look at the HSD picture. There are two entirely separate uteri. This picture, if you have got any difficulty in identifying, you look at the Leach-Wilkinson cannulae. Where are the cannula inserted through? Through the vagina only. So here, two cannula, you can see two cannula. Two have been inserted. That means there are two vagina, which means that the only condition where there are two vagina is in a uterus didelphys. So this is the picture of a uterus didelphys. Now we come to the next one. This is the arcuate uterus. Can you see any difference from a normal uterus? It is just that the fundus appears flat. That is all. It is a flat topped, or there is a slight dip in the fundus. Look at that. This is the one with the best reproductive outcome. It is the arcuate uterus. It is the one with the best reproductive outcome. If you are asked which is the most common Müllerian anomaly, the most common Müllerian anomaly is arcuate uterus. There is no doubt there. The recent Williams Gynec text says that it is the arcuate uterus. This is followed by the septate uterus and then the biconnuate. But if you are asked which is the most common anomaly that causes miscarriage or infertility, then your answer changes. It is a septate uterus. This is the, because arcuate uterus has got a very good reproductive outcome. This is the most common, and septate uterus is the most common anomaly causing infertility or miscarriage. Okay, clear? What is this? This is a bifid clitoris. This has got nothing to do with the Müllerian structures, but still, this is the bifid clitoris. Talking about the developmental anomalies, what is the investigation of choice for Müllerian anomalies? The investigation of choice for any Müllerian anomaly is the MRI. But if this is not given in the choice, then you have to go for a 3D ultrasound. But this is not the gold standard. What is a gold standard? The gold standard investigation is laparoscopy with hysteroscopy, which is followed by laparoscopy alone. Okay, fine.